paraphrasing him, but this
Yeah.
idea that
Yeah.
we end up paying it on the back end, and nobody's even blinking that you're spending $800,000.
Right. Right. Well, so we're spending over 450 now, but proposed is over 800. But that's just for one kid,
Right.
for 1 year. So, I was thinking about if we had $450,000 to say, what can we do for this kid and this family to prevent that? Think about how much preventative and interventions we could provide using that mind frame, investing upfront, not in the back end.
I'm sorry. Go ahead.
Oh, no, that was it. Yeah.
No, so I asked that
Yeah.
question because I think that's why it's worthwhile when
Mhm.
people start talking about these programs,
Right.
don't realize that this is really an investment in a more positive future, and certainly
Correct.
from a fiscal perspective.
Right. I mean, that's just fiscal, right? But if you think about what the actual impact on that child and that family, because when we CCS, CLTS, these are great programs that really can address the root causes of what later can get a kid system involved in the justice system involved. It can treat the whole family, work with the whole family. So it's not just mental health. That might be why you're in CCS, but they can also provide other services and supports for you.
What is the Children's Long-Term Support Program?
So the Children's Long-Term Support Waiver Program, it's or we call it CLTS. It's a Medicaid program. It's designed to help children and young adults who has a physical disability, developmental disability, or mental health disability. When you're talking about preventative, our program also helps prevent children from being institutionalized because of their disability. So that it's another preventative program that we also have. You have to have Medicaid and living in an eligible setting. An eligible setting could be your natural setting or living with a parent instead of like a institution or a residential area. So it goes along with being preventative, trying to keep them at home, being inclusive in the community.
So, and I don't know, Gail, we talked about the cost of, for lack of a better term, youth incarceration. What about the cost of youth treatment, where they're actually in a treatment facility as opposed to community treatment?
It can cost a lot. I don't have the exact numbers because it can vary. For example, if a child is going to be institutionalized, it could be up to maybe $1,000 something a day, just to be institutionalized at like a place at like Central Wisconsin Center or something like that. It could be up there. So our program is designed to keep children at home with their parents or guardian.
And just another thing about the costs, when you talk about later on when kids are justice involved, and if they're placed in an out-of-home setting, that can range, right? There's like different levels of care, and so it depends on that level of care. But it could range from a couple $100 a day up to $700 a day, depending on what kind of program and facility they're in. So again, if we're able to intervene earlier on, they won't even get to that point.
Is it possible for an individual to be duly enrolled in these programs?
For sure. Yep. We could have a child that is in CCS and also be eligible to be enrolled into the CLTS waiver program or the Children's Community Options program. So they can be duly enrolled. When we first started off with the CCS and CLTS duly enrolled, probably when I first started back in 2016 with Milwaukee County, we only had a small handful of children that were duly enrolled in CCS and CLTS. But now we've grown to up about a little bit over 200 children that are duly enrolled in CCS and CLTS.
Do you work in conjunction with the school systems?
We do. We have connections with the school, other community resources also.
Yeah, I think one thing if a kid is duly enrolled in CCS and CLTS, that really just be able to wrap around all the services even more. And depending on what their need is, and it allows opportunities for services, supports. It could be like home modifications. It could be like actual like recreation passes, whatever that child, that family need. Having both CCS and CLTS involved is just a greater opportunity for them. And that can continue way past when they turn 18.
Yeah, I was I was
Oh.
going to kind of
Okay, go, sorry.
No, you're fine. You're fine. Yeah, I think it makes it very unique because especially when someone is young, there's a lot going on, right? There's a lot of developmental changes, and you don't always know the root cause of things or everything that individual might need. And so, being able to blend the two programs, and we are working on new models that make it easier for the family. So, typically, if someone's in CCS and CLTS, they would have a worker in both, which makes it harder for a family, harder for them to navigate that and attend duplicate meetings, where now we're looking at models where it's one worker that is supporting that family in both programs. So trying to make it easier for individuals to get all of the services that they need and be able to help them navigate through that, because it's not easy.
If there's an assessment, what does that assessment look like in terms of making sure that that person has the right fit in terms of programming?
Yeah, so if someone is interested in any youth services, there's one entry point, which I think makes it easy for individuals. And we use what's called the Children Long-Term Functional Screen. So it is a screening process that will look at that individual, gather information, and then identify what services might be available for them due to their eligibility, and then being able to give them options counseling. So here's what might benefit you, and helping them be able to make that decision of what will be best for their family.
So I would just to go build off of that. There is one phone number you can call. It's a resource referral line. So it's one number. I'm going to say it now, and I'll keep saying it. Is the 414-257-7607. So if you call that number, they will be able to connect you with a screener who will be able to do the assessment and provide you all the different options.
Are referrals made? I'd ask again about your partnership with school systems. Are referrals coming from either community-based organizations, family-serving organizations, or school systems?
Yes,
Yep.
all of
Yep.
Yep, all of the above. Yeah, absolutely. Anyone can make a referral. So that's why it's important that we get this information out there, to get the phone number. There's a QR code you can use as well. Because if you don't know about it, you can't refer. So absolutely, we get referrals from families, community-based organizations, mental health, behavioral health, medical, schools. They come from all over.
When you said, I think you used the term for a lifespan.
Mm-hmm.
What, I don't know if you can, maybe I'm asking this imprecisely, but what does that mean, like a lifespan? I mean, up until I'm elderly, or what are we talking about in terms of a lifespan?
So for the CLTS program, our programs, it starts from from when it's birth to 18. When they turn 18, we transition them, try to do a referral to the adult program like Family Care or Iris. And if they're not eligible for Family Care or Iris, they stay in our program until the age of 22. So the lifespan is from birth to 18 for us, but then if they're not eligible for any other funding source like Family Care or Iris, they stay in our program till 22.
For CCS, when I say the lifespan, it is the lifespan. So we have individuals, again, as young as 5 and starting in the program, and then they'll transition into our adult services, and then can continue the length as long as they need the program and are benefiting from the program.
Yeah, because depending on, I would think the severity of either the mental health challenges or other things, it's not going to end when they turn 18 or 22,
No,
right?
absolutely.
I mean, it's still there. So now we're literally talking a lifetime.
Absolutely. Yep. Right.
We talked about dual enrollment, and you kind of gave a sense of how it works. So now, as opposed to I do it over here, you come through one person. So they would have one case manager.
We're piloting that model right now, so that there is one individual or coordinator, as it's called, that will work with that family and be able to help navigate both systems.
So this care coordinator really is trained and supported in both CCS and CLTS. So when you think about, if I was a family or a parent or someone who has a child and I have to work with 2 different workers, coordinator in CCS, a coordinator in CLTS, it's confusing. It's more time. We want to make sure that the experience that the child and family have is a positive experience, and we're adding value to their life and not making it harder. So how we can help navigate those systems is really the role of the coordinator as well.
I think we talked about this the last time you all were here. For some, there's a stigma in terms of reaching out for help. How do we help people overcome that stigma that they feel might be attached to them availing themselves to the services and the programs?
Well, I think, so one thing I think is having awareness and being able to, like, a lot of information is shared by word of mouth, or, someone that had an experience, or, you heard about this. So it's making sure we're communicating, marketing, and getting this information out there for everyone, and that people have that positive experience and can share that experience. Because I totally understand that the stigma and not wanting another system involved in your life. But it's how we show up, like our staff, how they show up and treat individuals, because we're there to help and support you. You tell us what you need. We're not here to tell you what you need or what you should do, but how we can work as a team. And so I think just it's how we show up every day and being consistent in who we are. And that includes all of our staff and our contracted partners.
Can I circle back, because I know we said that people were Medicaid eligible. That and so Medicaid is means tested. So what happens if I might not be financially eligible for Medicaid? Can I still take advantage of the services?
Yes. So our Children's Community Options Program is an option for families that doesn't have Medicaid, or they're not eligible for Medicaid. The Children's Community Options Program is pretty much state tax dollars. It's a limited funding source, but it's the same criteria. You have to be in an eligible setting. You have to be have some kind of disability, like physical, developmental, or mental health disability, to be eligible for our program. So with our Children's Community Options Program, or we call it CCOP or COP, we have families that are undocumented that are in our program because they're not eligible for Medicaid or not financially eligible. So that program is targeted for those families that aren't able to get into the CLTS waiver program or CCS program. So we can work with those type of families that doesn't have Medicaid.
When you say undocumented, would that also be inclusive? Because sometimes we have where the parents are undocumented, but the children are U.S. citizens. So are you talking that even when the children are undocumented?
Yes.
So when we're looking at that, so I guess when we take, because you get a sense when I heard Medicaid, obviously, certain things. So people can, even though they might be outside of Medicaid eligibility, they could take advantage of the program.
Yes, they can.
Yep. So even if you don't have Medicaid, you don't think you qualify for Medicaid, please still reach out, call the number, and we can do the assessment and determine from there. And even if we still aren't able to help you through Medicaid, there is still CCOP. So I don't want that to be a barrier, a reason why people aren't reaching out.
So we talk about Medicaid, but what if I have private health insurance? No.
Through through CCOP you could. CLTS you still have to be Medicaid.
Okay.
Yep.
Do it again, just so people can understand the difference.
Yep. So in order to be eligible for CLTS Children's Long-Term Support Waiver, you do have to have Medicaid. In order to, if you don't have Medicaid, private insurance, whatever that may be, you are still eligible for the Children's Community Options Program.
And CCS, you do have to be Medicaid, have a Medicaid plan. There is a small amount of grants that we are able to secure right now to be able to provide some services, but pretty much 90% of the individuals that come through CCS are on Medicaid.
What is, government, sometimes the application process can be pretty complicated and laborious. What would be the average amount of time it would take for one to apply, do the assessment, and then be enrolled?
So for the Children's Long-Term or even Children's Community Options Program, they call that resource and referral line. And the intake person will take their information. They will schedule something out to within, we try to do it within 10 days to schedule something to meet with the family to do that children's functional screen. And then once that is completed, it usually takes about maybe another 3 weeks until they're found eligible or not eligible. Even if they're found not eligible for our program, We just don't shut them out right away. We make sure that we go back to DHS and see if there's something else that we can do or change on that functional screen, to make sure that we can still find them eligible for our program. So it's not like, oh, you're not eligible, sorry, we'll close the door on you. We still try to find ways, if there's more information that's needed from the parents, to see if we could still get them eligible for our program.
I think one thing we're always trying to get to yes. So how can we better, how can we make sure that you're getting what you need? So after all that, if you're still not found eligible per the guidelines for CLTS, then we can make connections to community resources too. It's not, we do everything we can, we still are not eligible. What in the community exists that we can help connect you to? So again, we're not just saying no, goodbye, but connecting to other options, I'll say. And I think that's what's great about a resource referral and the options counselors that work with their families, that being able to make those connections beyond just a system.
What do you, I talked about stigma, but there are also cultural barriers. What are you doing in terms of being able to overcome those? Milwaukee is becoming more ethnically diverse, which means people bring their cultural understanding, certainly how they view government and government services. What are some of the things you're doing trying to overcome those barriers?
I think one thing initially is just around the marketing, making sure our information is available in all different languages, where we're putting the information out, making sure it's located throughout Milwaukee County. It's not just, this central area or this area. And it's also making sure we're having staff and our contracted partners that represent the clients and individuals that we're serving.
One of the other things I was going to share too is one of the big services that are offered through CCS is peer support or parent peer support. So when you talked about that stigma out there, also really finding parents who have gone through this and who can share their story with other families and parents, I think that is very helpful. But then finding that diversity of that. So making sure that we are bringing in and have a network that represents the people that we're serving, so that people feel comfortable and they want to come and be part of that or feel comfortable with the services that they're getting.
How do you encourage communities, like when you talk about undocumented communities, the fear that if they take advantage of a government service, they could be exposed, and probably looking at, possible deportation? How do you assure them that they're safe?
Sure. Everything is confidential. Everything's private. We just work directly with the families. We don't share anything with anybody that's coming in asking questions. Again, we just need, we're just working directly with the families and their child. We try to make sure that if anybody tries to ask questions about whatever, we don't give out any information for the families or about the families or their child.
And I'd say our care coordinators or staff, they spend a lot of time really getting to build that relationship with a family. So it's something that's not a short-term service where you get this and it's done. It's, when we say the lifespan, it is a lifespan, and you have to work to build that relationship to really understand the needs of that family or that individual, but then to build that trust, because you can't move forward or help and assist anybody if there isn't that trusting relationship. And so that is really important.
Yeah, when we're in the home, we're not there to ask questions about other people in the home. We're there just to focus on their child and the family's needs. Like if we go in the home and there's like 10 other people in the house, we're not going to like, hey, who's that? It's like, we're not asking questions. We're asking questions about their child and their family, what they need from their program.
And I think under our current atmosphere, you can understand where it's probably more heightened than it's ever been in the past, right?
Yeah.
And so that to make sure are you doing like outreach beyond this? Is obviously outreach, but some of the other things you're doing in terms of your outreach?
We've gone to like conferences around the state, Circles of Life. We've been to Children's Come First conference and like Southeast Autism of Southeastern Wisconsin conferences. So we've been out there. We've been in schools. We connect with other community resources like MPS or even Children's Hospital, which we'll be doing a presentation for Children's Hospital also, because they do deal a lot of families that doesn't have Medicaid or immigrants into this country. So we have I don't know the exact date. I have to find out, but we do have a training for Children's Hospital to meet up with them and talk about our programs.
I think, just another thing, we try to get out in the community as much as possible. So any type of community event, if there's a resource fair, anything hosted by any of our partners or any of the school, any of the systems throughout Milwaukee County, we try to have a presence. We'll have representatives there, just handing out information about our services and programs, just making connections with youth and young people. And you'll see that especially as it's getting warmer here in Milwaukee, hopefully. There's a lot of opportunities for us to be out in the community. We have a community engagement group at Department of Health and Human Services that is like, that's their focus, is how do we get the word out there in all the different communities across Milwaukee County.
So we've talked about this. So if people really want to take advantage of this, do you have some contact information or resources they can go to?
Yes.
We do.
Yes. Yes.
Very frequently the
Oh, you want to share it?
I will share it. Yeah. Let me.
The way you said it, like, yeah, we do.
So I will share. So we do. I'm going to share this number again. This is the resource referral line. I just want to make sure I get the right number. I don't want to,
Yeah. That's
Yeah. So it's 414-257-7607. And that number is it's one number, one line. Like, you can call. This is what I need. This is what I need help with. Or I may not even know what I need help with. This is what's going on in my life. And they'll be able to help connect you. We do have a QR code available as well. We direct you everyone to our website. There's information on our website, which I know is not always accessible. But this is a number. Please reach out.
It's one call. That's all. No wrong door.
Okay, because I don't know if we can do that one call. I think that's copyright.
Oh yeah. Oh yeah.
You're listening to Community Voice. We're going to come back and wrap this up. We'll be right back.
Inside Community Voice on WNOV 860 AM and 106.5 FM with your host, Keith Parris.
All right, welcome back. And we're inside DHHS Connect of Milwaukee County. And we're now joined at the table by Mr. David Muhammad, who is the Deputy Administrator there. Did I get it right?
Deputy Director.
Deputy Director.
Administrative Director. do stuff.
And
Try and make things happen from behind the scenes.
certainly Ramadan Mubarak. to you, my
Ramadan
brother.
Kareem, thank you.
So you wanted to join the conversation. I'm glad you joined the conversation. There was something that you really wanted us to go into a little bit more detail on. And so let's talk about that.
Well, number one, this is a great team, and super appreciative, myself, Director LeGrant, of the team that you have assembled here, Kelly, Toto, and Beth, for the work that they do. We integrated several years ago our children's behavioral health services with our children's disability services, with some of the services that we were offering in the youth justice space. One of the things that we found was about 60% of the young people in our detention facility had an undiagnosed cognitive disability. There were other challenges that
Give that percentage again.
60%. And so, when it's being found in other parts of the system, that means it could have been, found earlier through earlier intervention, screenings, programs like Birth to 3 or CLTS or CCS, that is comprehensive community services. And what I felt passionate about with this team and the work that they're doing now with children, youth, and family services and, behavioral health is that those types of resources are being provided in the community in a multitude of spaces. We have partners like Owens Place on the south side, as well as on Fond du Lac, which is a resource drop-in center for a lot of these types of services. We have a lot of community partners that do this type of work, and we have people who we are working with at multiple levels, like Kelly was mentioning. When you call the Children's Resource and Referral Line, that connects you to all of the things that we have available for young people and your families. There's the work that we're doing with Credible Messengers, as well as with other providers in the community, that I think is a big deal. And I did want Beth to speak about CCS, about comprehensive community services, because we are seeing that as a big opportunity for growth in terms of serving young people of color in zip codes and areas where the resources may not have always been, and where the services that would have been identified for that population might not have been the right fit. And so there are both clinical and non-clinical approaches that are available. And there's a lot of people who look like the folks who are being served doing the work. And it is a big deal. And I think it's something that folks in the listening audience should know about.
Yeah. And so one of the things when I was listening to you talk, David, and you were asking before about kind of that diversity, we've have a huge effort of making sure that our network actually matches the people that are receiving the services. So specifically when we put out a request for proposal, which we will do again later this year for new providers, we specifically look for providers who are in those zip codes, who serve different populations or have a very diverse staff. So we're constantly looking at that because we know that we will get better outcomes of our youth, more engagement, more relationship building when we can make those true connections. But CCS is very unique. It's a very unique program where we provide those traditional therapeutic services like psychotherapy, med management, could be some psychoeducation for families and understanding what their loved one is going through. But we have this opportunity to look at recovery differently and realize that it is an entire person. So when you don't physically feel well, that affects your mental health. So looking at things like yoga or we have some new nature-based services. So getting kids out into the community, into the parks, doing activities. We look at not therapy just as talk therapy, but music therapy, art therapy, being able to use their hands to create something is a way to help somebody develop a coping mechanism or just develop a way to connect with themselves. I mentioned equine therapy. That is very, very popular service, but really, again, gives individuals an opportunity to take empowerment over what they're doing. They have control when they're up on that horse.
I was going to say that's horses,
very
right? That's
cool
horses.
to see.
Yes.
Very cool to see. We had a chance to go and visit one of our Willow Creek Ranch and actually spend time. And it is very interesting how animals, horses specifically, they can read people,
Right.
and they match your level of where you're at. And it was a very cool opportunity. But then again, even going through, we are building things, focusing on nutrition. When someone isn't able, again, feel well, have the right nutrition in their body, that can affect mental health, their ability to focus at school, all of those things. So helping individuals to look at that, anything from benefits or financial budgeting, employment. We use an evidence-based model, individual placement and support, to help connect individuals with jobs or opportunities, because we do know at a young age, when they're given those experiences, that's going to affect their employment outcomes in the future. So you really can look at a variety of different things. That whole, we call it the wellness wheel, but there is a whole wheel of looking at a person and all aspects of their life, and how does that affect someone's mental health and their ability to be move forward in life.
I think as you're talking, there is no one thing that works for everyone. So being able to offer like this huge continuum or ecosystem of services, I think is key, because what works for one is not going to work for another person. And another thing is what we have, like you talk about what impacts you and what you call it, the wellness circle,
Wellness wheel.
wellness wheel. There's different things that impact that aren't necessarily provided by CCS, but what we're able to do is make those connections. One thing I often think of is housing. And so we also have our housing services within DHHS, and we have a navigator whose job is, navigators throughout the DHHS, whose job is it to help make those connections to all the different systems and opportunities for young people and their families.
So when we say no wrong door, I mean, literally any entry point or any touch point that a family or a young person would have with the Department of Health and Human Services, we want to be able to serve them, the members of the household, and the multitude of needs that they might have. And if they present with one, it may identify others that are possibly more of a stabilizing need that would allow us to address other complex needs.
Can you, just for our listening audience, describe the concept of wraparound? We hear it. I don't know if we clearly always understand it.
So I think wraparound to me is how you engage with that family. It's not a program necessarily, but it's how you wrap around whatever services are needed. You wrap that around the family. So think about whether it be behavioral health, mental health, behavioral health, housing, whatever that, food insecurity, whatever that family needs, you're able to address that and wrap all the services, all the people, whoever their team is around them, and be able to meet them where they're at and help them get to where they want to be, what they see for their future.
And I think it's important to recognize that a thing like housing, if someone doesn't know where they're going to wake up in the morning, if they're going to have a meal in the morning, that affects so many other parts of their life. It affects what's going to happen in school, or are they going to be able to talk to their friends? And so again, looking at that entire person, that family, and again, making sure that we're addressing the wrapping around and addressing everything is really going to help that person be successful.
And we did, the HMO of wraparound is what shifted. And now we've gone more into the direction of comprehensive community services and other supports within the department.
You say the HMO?
Yes, the Health Maintenance Organization. Wraparound functioned as a HMO, and now it's more of a coordinating body within DHHS for the types of services that we're describing. So it didn't go away. The network didn't go away in terms of the providers, but the way that we were funding it has changed. And I think, honestly, for the better. It's expanded a lot of what we're able to do and what we've talked about this morning.
Because you hear terms like holistic, right?
Yeah, absolutely.
And what that meant. And I think sometimes you hear it, but you can't always visualize what it looks like, because, we're not part of that. What about, and I hope I'm not sounding too trite, this idea of cultural competency in terms of staff and service providers?
I mean, it's important. It's critical for us. I mean, I think we're very proud of the work that we've done at Department of Health and Human Services. We're, we've leaned in heavily over the last several years on this. And even though things might be shifting nationally in terms of tone, the work remains the same. The needs remain the same. And the best practice is the same.
Mhm.
that you have individuals who are relatable, who understand the root causes, as well as are not guilty of functioning from a space of bias or pathologizing the people that we're serving. You can't really serve people you feel superior to in the right way. So you have to recognize, the human, the nature of us as human beings and relating to each other. And I know people want to, do away with words like or letters like DEI and stuff like that. But ultimately, culturally competent services means respecting the cultural norms of the community that you're serving, respecting the integrity of what makes them a supportive and cohesive environment, even though it might not fit the template of another community, and at the same time having resources and a method of communicating those resources that they can identify and see themselves in.
If depending on the educational background, but people who would study social work in college, people who got their MSW, how do you, where we've learned theory, how do you temper that theory with reality?
Work in Milwaukee.
Yeah. I think one thing we've looked at is who are we hiring? Like, what is their background? And typically we used to place a lot of value on education. Did you get a degree? But I think the learning really happens like living life, right? So it's not necessarily about, you don't have to have a degree to do this work anymore, but you have to have that experience, and that's what we're looking for. What is your experience, your life experience, your work experience? How do you show up? So we're looking beyond just having a degree, because they don't teach you in school a lot of what you need to do to be successful and really be able to connect and meet people where they are and be able to help.
Well, that's the problem with
Yeah.
majoring in saving the world.
Well,
Yeah.
Well, I would also lift up, you have folks who are master's levels clinicians, right? They have a degree and a lot of preparation, but they can't do the work of some people who are identified as peer support.
Mm-hmm.
And so we've used more individuals in the peer support space for behavioral health, for substance use disorder, for youth justice in the violence prevention space, people with lived experience who are not necessarily to be seen as paraprofessional to somebody else. They might work under the clinical supervision of a team member, but ultimately they're the primary care provider for
How
that
do you
person.
navigate that? There's conflict there. I've seen it. There's conflict. How do you manage that conflict?
What kind of conflict?
Well, there's conflict between those folks who are not lettered or degreed as opposed to people who are peer. And I'm not going to use the term professional. They both are professional.
Mm-hmm.
But there's the community, right? And what we've learned, PhD of the streets. And then you have someone who might be college educated. Yeah. And so when you're doing that, there can be conflict there, right?
Yeah, well, we've worked really hard within the CCS network to define what that role of a peer support is, and to make sure that everyone understands that it's not a friend, it's not a buddy, but they're there for a purpose, and being able to help that individual deal with whatever is going on from the experience that they've had. So I think a lot of it is conversation. It's putting that this is what this role is and putting it out there so that everyone can see it and hear it and know it, at least within the CCS network, and understand the power of that. And sometimes it's that person that can really connect with somebody versus their clinician or somebody else. So I think it is just, it's for us, it's really how you describe it, how we're putting it out there, how we're talking about it, how we're seeing that person as part of the team. They are not necessarily, like I said, this friend over here that's just there to help it. They are a member of that team. They're on the plan. They're helping that person, and collaboratively doing that.
I've had this conversation about people's lived experience and how we bring our lived experiences in. David was talking about biases and things like that. So in terms of when you walked in the door, you had a sense of where you think this should go. What have you learned since you walked in the door? What your intention, and how much has, for lack of a better word, reality has pushed up, as David said, work in Milwaukee. What has been, just your whole personal, if that's kind of where you are? Is there evolving in terms of, so what would
I mean,
that journey be like?
absolutely. I think from when I first started working for the county, maybe 12 years ago or so, to where I am today, completely different. And if you're not evolving and changing, then you're not the right person to work in this field at all. So I think what we really pride ourselves on, and me personally, is like being open to learning. I know I don't know it all. I don't have, we all have different experiences. I don't know what you've gone through or what someone else has gone through, but recognizing that and being open and having that open mind. And I'm constantly learning something new every day, which is why I love working for DHHS and love doing the job that we all have the opportunity to do.
I was gonna say, add to that, like I'm always evolving too, and all of our staff or human service worker that does CLTS, we're always evolving. There's always different situations that we walk into, and we have to be open minded and on how we deal in different situations with families that we come across. Because some families may not need a lot of things, but they don't understand that, and we have families that may need a lot of things, but we have to work with them, and it just partnering with the families that we work with, and it's always ever evolving. Since I started, I've been in this field for I think over 15 years now, and it's always growing. It's never you're an expert in one area. It's always you're learning. You can be an expert in a certain area, but then you just continue to learn more as you go. So it's always evolving for me.
Yeah, so I've been at the county for 6 years now, and definitely always learning, always learning every day. I think for me, coming into this field and over the last 5 years, I guess just coming to the understanding that any one of us can be where any one of the people are that we're serving any day. And so really, again, approaching each individual how I would want to be approached and how my family would want to be approached. But really, again, and then understanding that everyone needs something different. I think we talked a little bit about that before, but I think that that's just so powerful that there is no cookie cutter approach to anything that we do. And really making sure that we're taking each individual's experience and then figuring out what's going to work best for them.
I understand how we create departments and so departments have to have a name. I don't know if sometimes we're always in tune to the name and what it is that department is supposed to do. And one of the names or part of this DHHS is human. Mm-hmm. And I think that sometimes because it's government, humanity can be lost in that. And that's why I guess I asked that question in terms of making sure that when we provide the service that we realize that we're providing Ubuntu, right? This human to human service that we provide. And I know that sounds really philosophical, but your philosophy will definitely drive your approach.
But it's real. I mean, when we talk about person-centered care, that's a lot of what you've heard discussed today is collaboration across our different service areas within the department to meet the needs of a family, of an individual, based upon whatever they're presenting with. All right. It first has to be us recognizing those needs that might be said, stated, and unspoken as well. I think that from the vantage point of the teams that we have inside of the department, that has been a shift for us because before we got on this journey of no wrong door, it was largely about what we were statutorily required to provide and what we were funded to do. Now our whole purpose is to get to yes. And as you heard discussed earlier, when you were talking about mixed status families, where you have, a child who might be a citizen and a parent that might not. I mean, when you go to a hospital, you want someone to treat you for the need you present with. You don't want them to give a barrier to your wellness. We have a lot of people in Milwaukee who have those types of needs, and they need to know that these resources that are taxpayer-funded resources are available for their well-being and for the well-being of their communities. And I think when we organize ourselves around that principle, it becomes the culture of the department. And we've come a long way in that regard.
Yeah, I think, because as you say, especially if you're granted, there is some quantitative things that people are looking for.
And you use, folks can use bureaucracy to find a way to say no. We're doing the opposite.
Right.
Well, I was going to say, I mean, there are, when you talk about some of the funding sources, there are certain things you have to show and prove, and you have to have data, which is all important. But then looking beyond that, it's so much more than that. So everything we do, we think about the child, the family at the center, and then whatever we have to report on, whatever we figure that out on the back end. That should never be the experience of that client that we're serving. That's up to the professionals working behind the scene to figure that out.
Yeah, I just think, like I said, it's easy to get caught up. I think David talked about bureaucracy. It's easy because now it's the culture, right? If you go out and something will come out, you ask. I will ask myself, what is the culture of the place? And if you have where people are more on the quantitative side than they are on the qualitative side, then I think the people served will suffer, right? So to make sure of that piece, and people, oh man. We do countless interviews on why would you want to do this kind of work, and we just took it off. I don't want to hear because I love people. I hear that because that's great, but then once people get past probation, you find out maybe they don't love people as much as they alleged in the interview. So to make sure, what are you doing from a leadership position to make sure that the humanity is not lost in all of this?
I think so. It starts from the very beginning. When you're looking at who you're going to hire or who you're going to contract with, we do our interview processes a little bit different. We've changed like the requirements just to get more people in the door, get more people a variety of experiences. So it's not just those recent college graduates, but it's broader selection. But then we do different types of interviews because anyone can interview well and they can say, yes, I love people, I want to do this, I have a passion for it. But then when they show up, it's like, who are you? Like, it's a totally different person.
They actually met the people.
Right. So it's making sure it's asking the right questions of people. It's more than just let's sit here and talk for 5 minutes and you're done. But seeing how you show up. But we do, once you're in the door, it's so important that we continue to support and coach you through your journey. And if it's not the right fit, we will call it out. We don't want people here just for a paycheck. So it is a challenge. So yeah.
But I was just going to say, our director too. Shakita sets the tone.
Yep.
And that's echoed throughout all our leadership.
I used to say, as a manager, what I discovered was that I had people on the counter who really should be on fries. You know what I'm saying?
Yeah.
And so,
that warm welcome, that's a big deal.
Right. No, I'm just saying, in terms of dealing with the public and how you deliver that service,
right?
That
will make or break how you show up and who you are and how you interact. Yeah, and that's why even from our clerical administrative staff, that's the face of a lot of people when they walk in the door. So even them, we train everyone receives the same trainings and supports and gets the same message. You were representing DHHS.
Yeah, because you say no wrong doors, but that front door.
Right.
The
has a whole lot of impact on
somebody who likes to say no.
Yeah. Right. Let me thank Beth Lohman, Kelly
Pepke, yeah.
Toto. Yep, just like that. David Muhammad. Let me thank you all again. This is Connect with DHHS, Milwaukee County Department of Health and Human Services. Really appreciate you coming in. Good to see you. Good meeting you. Good seeing you all again. Hey, the good Lord willing, creek don't rise. We hope to talk to everybody tomorrow. And as always, go from this place in peace.